the easiest way to do it. So if I'm looking at our arterial disorders, the disorders that you wanna know about are going to be things like aneurysms, aortic dissections. Aneurysms can occur anywhere, so aortic, femoral, popliteal, you can have thoracic. Make sure you know the symptoms that are different between those different locations. We wanna know about arterial occlusive diseases, which is going to be our peripheral artery diseases, PAD. And that can also occur anywhere. Specifically, we wanna know about the lower extremities. And then we wanna know about our acute ischemic disorders, and those are gonna be things like Raynaud's and Berger's disease. So looking first at aneurysms. An aneurysm is gonna be an outcrouching of a vessel. And really, it's going to be named based on the vessel that's having the problem. So one of our most common is going to be the aortic aneurysm, and this is going to cause the aorta lumen to widen, and then it is going to cause the blood flow to slow down. It can cause an outpouching. I'm going to show you some different pictures, or some kind of abnormal dilatation in the arterial wall. Either way, it's pulling the arterial wall, and it is going to stress the vessel, it's gonna weaken the vessel, it cuts down the blood supply. Biggest risk factors, CAD, hypertension. Hypertension in this instance is the #1 risk factor. So don't, if I'm asking you about risk factors, don't get confused at the fact I've said CAD, #1 is smoking, we have the obesity, we have the weight gain, but if it comes down to it, and I'm asking you about aortic aneurysm and the #1 risk factor, hypertension, #1, you need to remember that. We need to control hypertension, because the last thing we want it to do is rupture. So if we think about aneurysms, especially in the aorta, we need to control blood pressure. Most common location for an aortic aneurysm is gonna be between the renal artery and the aortic artery, so that's really where we see them the most. The least common are gonna be aneurysms in the thoracic aortic area. Most of the time, patients with untreated abdominal aneurysms that are greater than 6 centimeters, and we're gonna gauge them by centimeter size, will die within 2 years of the diagnosis if they're not monitored and treated correctly. So when we look at overall classifications of aneurysm, we can have 3 different kinds. We can have a saccular aneurysm, which is an outcrouching of the vessel wall, and I'll show you a picture. Falciform is going to encompass the entire surface of the aorta. So it's going to kind of be like an outcrouching, but it goes around the entire one. And then you can also have a pseudoaneurysm, which is a false aneurysm. This happens after things like vascular surgery. So like somebody who's went to cath lab can have this, and what you have is an injury or some kind of puncture to the arterial wall. It breaks all the layers of the wall, and blood starts to leak out into the surrounding structures, and it creates a pulsating hematoma, which really is not an aneurysm at all, but it looks like an aneurysm when you're feeling it. So here's our most common aneurysms. Again, saccular is that outcrouching, and then the falciform circles around the whole aorta. Biggest complication is going to be the rupture of the aneurysm. When I'm looking at patients who are having problems with aneurysms, the bigger the aneurysm gets, the more symptoms they're going to have. So when I'm looking at symptoms, pain and hypotension, depending on the location of the aneurysm, some of the symptoms can change. So if the aneurysm is on the aortic arch, which is really up high, right off of the heart, some of the things that they may complain about as the aneurysm gets bigger: angina, hoarseness of the voice, JVD, edema in the face and arms. If it is in the thoracic area, technically it could be totally asymptomatic here because you don't have a lot of nerve endings. Sometimes they will complain of deep pain in the thoracic area. Abdominal, depends on how big it is. You can see that pulsating mass in the periumbilical area, and remember, if you ever see a pulsating mass, we do not palpate the abdomen at that point in time. You can hear a bruit, which is why we're listening with the bell of the stethoscope over the aorta and the renal arteries. Back pain is one of the biggest complaints associated with the enlargement of the aortic aneurysm, and altered bowel elimination if it puts pressure on any parts of the bowel. As the aneurysm gets larger, if blood pressure starts to drop, a blue toe syndrome. This is a modeling of the feet and toes due to poor peripheral circulation. And then this, with the pseudoaneurysm, so this again is following a procedure that has potentially damaged the walls of an artery. We get swelling pain at the insertion site, it's a hematoma, you can still get the pulsating mass, you can have bruit, you can feel a palpable thrill over the mass, and then you get extensive ecchymosis because of the bleeding around that site. So LAPS is what you want to remember as clinical manifestations for our aortic aneurysm, and that's lumbar pain that's radiating to the groin. If we have this pain and it's radiating to the back of the groin, it's actually a sign of an impending aortic rupture. So we want to remember that. Abdominal tenderness with deep palpitation, pulsating mass in the peri-umbilical area, and then the systolic bruit over the aorta. Diagnostic tests, the biggest one, CT MRI, this is going to determine the size and the shape. They can do an angiograph looking at the condition of the vessel if they want to. And then, of course, a chest x-ray or abdominal x-ray can help to identify aortic calcifications or outline the mass itself collaboratively. We're going to, number one, treat hypertension. Absolutely have to make sure that blood pressure is controlled in order to prevent rupture or dissection of the aorta. With a small aneurysm, we're talking less than 4 centimeters. This is where we have our conservative therapy, which is treating hypertension, and then we're gonna monitor them every 6 months with something like a CT. Anything greater than 4 centimeters or a mass that is causing symptoms, like the blue toe modeling symptoms that I told you about, they can do endovascular stent grafting. We're gonna take them to cath lab, we're gonna put in a stent here, and I'm gonna show you a picture to explain how the stent is going to help. They can also do the surgical resection with the endovascular bypass graft, so this is gonna be things like our aortic, our AAAs. We're gonna send them down, they're gonna cross-clamp the aorta, they're gonna put in a graft. And that's usually gonna be a Dacron graft that they're gonna put in. I think I have a picture of that as well. With the pseudoaneurysms, if they're small, they may spontaneously thrombose and won't require any treatment. We can do things like thrombin injections. They can do compression maneuvers, ultrasound guided compression, arterioplasty, which is gonna be the repair of the vessel. So if they send them to surgery, they can do a repair. And then they can also go for endovascular stent grafting. Let's see where I put the picture of the graft before I jump into. I want to show you this one. So if we were going for the endovascular stent grafting, they can do this in cath lab, where they're going to put the stent in, and you see then once that graft is in place, especially in that falciform aneurysm, now the blood can't collect in the aneurysm, it is going through the graft. So this is going to help prevent the person from getting a rupture of the aorta. So this, looking at that picture, then I'll backtrack to the actual surgery itself. So if I'm going to send somebody for a vascular repair of some sort, patient prep, really same thing. I need my consent signs. We're going to teach them about the signs and symptoms that they need to watch for, and we're going to teach them about the surgery itself. Post-procedure, very similar to things that we learned about open heart, except we're not opening their chest in this situation. They're going to be in ICU. From there, they'll go to a step down like medical surgical. We're going to manage pain, of course, splinting, again, for coughing, deep breathing. Big things with the opening of the aorta is that we need to check the feet. Initially, when they come back, if they were not having good circulation to their feet, once we open up the blood supply, their legs and feet may get red, they may feel tingly, they may feel burning. We're going to be checking for warmth, strength, movement, color, capillary refill time, but as soon as the blood starts to go into the legs, it may be more painful than they were experiencing before they had good blood flow. Gradually increased activity is tolerated. However, we need to think about where the surgery was done at. A abdominal aortic surgery is going to be different than a femoral bypass type surgery. So we need to think about where their surgical site is and how long they can sit up without putting stress on that surgical site. So of course, the femoral area is gonna be different than the abdominal area. So we're going to gradually increase activity. Most likely they'll be out of bed like that same day or the next day. Signs and symptoms of infection, bleeding, and then compression devices to help prevent DVT. Home care, we're going to teach them to check their pulses before getting out of bed in the morning. We're gonna notify them empty of any symptoms of a DVT, so coldness, pallor, numbness, tingling. Continue with exercises that they're given, coughing, deep breathing, and they're gonna avoid lifting more than 10 pounds for 4 to 6 weeks. Signs and symptoms of infection, and they may go home on some kind of anticoagulant therapy. So if they go home on Coumadin, well, we need to teach them everything about Coumadin, bleeding precautions, and the effects that they're gonna need to be monitored for INRs. Endovascular stent grafting, I just showed you the picture of the stent. This is done in cath lab, so everything that you know about following a cath lab procedure applies here. So just apply that knowledge right there, what we do post cath lab. And then the bypass grafts. So with the bypass graft, this is usually a diaphragm graft. They're gonna clamp the aorta, actually they cross clamp it, and then they're gonna remove that aneurysm piece, and then they're going to repair it, either the damaged portion, and they're gonna use a sewn-in diaphragm graft right into place. And occasionally, they can bypass as well if they need to. If they don't remove the piece and they just wanna bypass around the aortic area, they can also do that, and they would harvest a vein from somewhere else in the body. So you may have a second insert and second site, just like when we talk about open heart and we harvest the vein and they bypass around an open heart, they can do that as well if they choose not to use the graft. So here's a picture of what's going on with the diaphragm graft. So here they cross clamp the aorta, they open it up, they sew the graft in place, and then they sew everything back together. Questions on the surgery? The biggest thing to watch for, the biggest complication of our aortic aneurysm is going to be the rupture. So a sudden rupture or tear is gonna result in a massive hemorrhage. They're gonna go into hypovolemic shock, and if we don't catch it quick enough, they're just gonna die. It's a medical emergency, prompt treatment, but really, if your aortic ruptures, you have like a minute. Because think about how much blood goes through your heart every minute, that's your entire blood supply. Now, an aortic dissection, though, is a little bit different, because an aortic dissection is not immediately rupturing, but we do need to get the person in surgery before the aorta totally ruptures. So if I'm talking about a dissection, this is going to be a tear in the aorta. Most of the time, what's happening is that there's a weakened area, could be due to an aneurysm, could be due to something else, and it's allowing the layers of the aorta to split or to tear along the aortic wall. So there are some standard classifications, type A and type B, that's most commonly used. So in type A dissections, this is usually the ascending aorta and aortic arch. This is treated surgically. And then the type B is usually the descending aorta, and this is going to be managed medically by controlling blood pressure unless the tear seems to be symptomatic or getting larger. Clinical manifestations of a dissection in process is going to be a sudden, severe abdominal pain, tearing. It feels like a tearing, ripping, burning, radiating to the flank or the back. So if you hear this, you want to think aortic dissection. It can also be accompanied by sweating, nausea, vomiting, weakness, syncope, tachycardia, hypotension. Symptoms are always going to depend on the location of the tear as well. Some things that you may see: blood pressure differences between the arms and the legs, pulse delays between the arms and the legs because the blood is just not getting down into the legs the way it should be. They can start to go into hypovolemic shock, so you may see cardiogenic shock, fluid backing up into the lungs with any type of shock. New heart murmurs, onset of stroke-like symptoms, paraplegia. If all three layers of the aorta dissect, now you have an aortic rupture, and that's emergency surgery, if we can get them there in time. As far as diagnostics go, Same thing, your choice of an aortic angiograph or a CT of the chest and the abdomen are probably the most common of the diagnostic tests that are gonna be most helpful. As far as conservative therapy, for that type B dissection, medications aggressively to control high blood pressure. The other thing they could choose to do if the dissection is due to any type of aneurysm, they can do that endovascular stent bypass graft. And then in an emergency situation, they'll send them for the aortic aneurysm repair. So everything that we just talked about with the aneurysm repair applies to the aortic dissection that goes to surgery as well. Questions on the difference between the two? Right. With our femoral popliteals, so they can also have the aneurysms here, same thing. Usually this is a falciform type aneurysm. It can be in one or more locations. Most commonly, this is affecting men over the age of 50. Sometimes people who have abdominal aneurysms are at higher risk for having also a femoral or a popliteal aneurysm at the same time. Symptoms, if it's popliteal, you get pain, edema, vessel distension, widening pulses, symptoms of ischemia to the foot or to the leg because the blood is just not getting down past the popliteal artery. Femoral, usually what you see is a widening pulsating mass in the femoral area. So we're going to treat this surgically with a saphenous vein graft replacement to replace the area, either femoral or popliteal, that is having the problem with the aneurysm. So commonly this is referred to as your fem-pot bypass surgery. You're going to have more than one site. So this is just looking at a fem-pot picture so you can see. They're going to harvest the vein from the opposite leg. So both legs are going to have an incision site usually. And then they're going to bypass around the aneurysm section. So post fem-pot bypass, stabilized, usually sent to a med-surg unit. Most of the time they don't need to go to ICU following this type of surgery. Manage pain, splinting, coughing, deep breathing. We're going to always be watching those peripheral pulses in both legs, warmth, movement, color, capillary refill. Again, the lower extremities can be deep red and warm. They may complain to them as the blood or the circulation is returning to the legs. This would be considered something normal, not a reportable finding. Gradually increase activity as tolerated. We are going to be getting them up out of bed, but here we need to think about where our incision site is. If it's in the femoral area, we're going to avoid very prolonged sitting in the high followed position because of that femoral incision. So we're going to have to gradually build up to that. Monitor incision site, signs and symptoms, infection, bleeding. Questions? All right. PAD. So with PAD, this is going to be peripheral arterial disease, and it is going to vary from minimal to ischemia. It just depends on how bad the occlusion is in the arteries, and we're usually talking about more the legs than the arms, but again, it can occur in any of the peripheral areas, and if somebody has PAD at the lower extremities, you kind of bet that they probably have it at the upper extremities as well. So what we see with PAD, most of the time is caused by atherosclerosis. So we already learned about that with the heart. Now we got the same thing going on in the periphery. So narrowing of the lumen of the artery associated with inflammation, reddency, pain, swelling in that area, as well as endothelial lining disruption. Because remember, as the blood is being forced under high pressure through that narrowed, it's tearing some of the inside lining. Sets up the process of inflammation, sets up the process of clotting. They always go together. So our big diagnosis here, tissue perfusion problems, ischemia. This is an artery. So if I'm cutting off arterial flow, I'm cutting oxygen from going to the lower extremities. It can lead to thrombosis, it can lead to emboli formation. So if I'm in an artery and I have a thrombosed area and it gets an emboli, where's that emboli gonna go if it's in the legs? I'm in an artery. If I'm in an artery in the leg, maybe I'm in the femoral. Let's just start with the femoral. I'm in an artery. Arteries are carrying blood away from the heart. It's going to lodge in a smaller artery or a small capillary further on down that leg. grab, it's gonna pull it down, it's gonna lodge in the smallest things. Probably not gonna travel all the way through the capillary system up into a vein to get back to the heart or the lung. So think about your anatomy, what's going on with it. If I have this thrombosed area and peripheral arterial disease in one of my larger arteries of the leg, there's a good chance I'm gonna end up with clots, or thrombus, or an emboli in a smaller artery on down in the leg or the foot. All right? So what we see are things like vasculitis, inflammation of the vessels in the legs. Many times, this can also be due to trauma. If I have a trauma or injury to a vessel in the leg, it can set up this inflammatory process, and it can also cause it. So we can have arteriosclerosis as a cause, but we can also have a trauma as a cause. Biggest risk factors for pulmonary arterial diseases are PAD, smoking. Well, smoking makes everything worse when it has to do with arteriosclerosis. So smoking, again, aging, diabetes, hyperlipidemia. Elevated CRPs is really just telling me that there's inflammation in the body, so this would be positive. Uncontrolled hypertension, family history of anything cardiac. Risk is always greater for men with PAD. Now, again, PAD can affect any artery of the body. So carotids are frequently affected. If my carotid has problems with arteriosclerosis and I'm getting carotid blockage, or I have a thrombus going on in the carotid, well, now I'm affecting blood flow to the brain, which is going to increase the risk of the stroke. So in this instance, I need to go in there, I need to get all of that gunk out of the carotid artery. This is a carotid endarterectomy. They're going to open up the carotid artery, remove all of the thrombus or inflammation or arteriosclerosis that they can get out, so back up, so we prevent a stroke from occurring. We can have PAD of the vertebral, subclavian. These are probably some of the less commonly affected areas. Mesenteric celiac. Now, this can send thrombus areas or decrease blood flow to the bowels. So think about somebody who is having now symptoms of arterial dysfunction in the bowels. I'm not getting blood flow to my bowels. They're not working correctly anymore. Parts of the bowels can die. You can get gangrene in your bowel from lack of blood flow there. So again, they can complain of abdominal pain, swelling, constipation. You would have like, hypoactive bowel sounds. So that's all mesenteric problems. Femoral popliteal tibial, these are the most common locations for PAD, and this is blocking the blood flow to the legs and the feet. So our surgery that we talked about that helps to remove this problem or to get rid of arteriosclerosis and or aneurysms are going to be that MPOP bypass. And then our associated diseases that can go with this are going to be things like Berger's disease and the Raynaud's. My classic symptom of PAD in the legs is intermittent claudication. So this is going to be ischemic muscle pain that is precipitated by constant exercise. So I'm walking, and my legs hurt. If I stop walking and sit down, the leg pain goes away. Think about stable angina. It's the same thing that's occurring in the legs. It is the exact same situation. The exercise is demanding more oxygen, blood flow to the muscles than can get there because of the blockage. Usually resolves within 10 minutes or less with rest, and it's reproducible. You have them walk again, the pain comes back. They sit down, it goes away. This is telling me that I have some kind of diseased artery or some kind of blockage in the arteries of the legs. Now, in some people, you may have the growth of collateral circulation, just like we had in the heart. The more collateral circulation you have, the better oxygenation you're getting to the tissues in the legs. They may not even know that they have peripheral arterial disease in the legs with a good enough collateral circulation. So what you want to remember are the 5 P's, because these P's tell you that now I'm thinking that I have an occlusion. So it's pain, pallor, pulselessness, paresthesia, and paralysis. Those are the 5 P's that say I'm not getting enough blood, or I have an occlusion in somewhere in the arterial system of the legs. Other clinical manifestations: thin, shiny, taut skin, loss of hair on the lower legs. How come? Why did the hair go away? Lack of oxygen to the hair follicle. No oxygen, the cells are gonna die. Reactive hyperemia, this is deep red skin when the extremity is in the dependent position. And then rest pain. So this can occur in the forefoot of the toes, aggravated by limb elevation. So if they're laying in bed and you prop their legs up and they're complaining of cramping and pain in their feet, you wanna think PAD. Or you wanna think about blood clots. So this should tell you, with an arterial clot, we are not gonna prop their feet up on pillows in the bed if we know they have an arterial clot. Pain usually occurs more often at night with these and from the insufficient blood flow, and it can be relieved by keeping the extremity in the dependent position. So for these patients sitting up in a chair, again, we don't wanna prop their legs up if they have peripheral arterial blockages. They need to be in a dependent position to allow gravity to push as much oxygenated blood to their toes as possible. Start keeping the difference in your head about what to do with an arterial problem versus what to do once we talk about DVTs. So our signs and symptoms here come in patches. Pulselessness, altered appearance of the extremity, temperature differences, so the leg that has a blockage and it can be cool. They usually have the hardness of the tissues. They get the toenails that are very thick and rigid because they don't have oxygen getting to the toenails. So those are the yellow toenails. Edema is usually minimal for these patients and it is not pitting. Sensation abnormalities, pain, tingling, numbness is what you'll typically see. Now, if I am not getting oxygen and the tissue is dying, where am I gonna see wounds forming for these patients? Due to lack of oxygen. Not for the arterial. Think about your furthest, your toes can start to see it. Your feet and toes, they can become black, they can become necrotic, they can become gangrene. The wounds, they could be. The wounds are gonna usually be seen on the feet first, on the toes. So this is, you can see the difference in color of the legs here. You can see where the toenails get thickened, and you're going to see feet, toe problems because of the lack of oxygen getting to the furthest points, being the feet. You also see things like atrophy of the underlying muscles, delayed wound healing, wound infections, the arterial ulcers, we already talked about the location, and then very frequently tissue necrosis and gangrene can develop. Things that they can do diagnostically, they can do duplex Dopplers, which is a non-invasive Doppler, and it's going to look at the pattern of blood flow through the arteries and through the veins. This is a good way of locating the extent of the PAD. Also determines the level of ischemia with the duplex ultrasounds. And then we can send them to the cath lab and they can do an arteriograph looking at the arteries themselves, and it's very useful to say whether or not the patient is a good candidate for reconstructive surgery of any of the arteries going through the cath lab. Now, the ankle brachial index, you should know how to calculate this. This is done using a handheld Doppler. You are going to find the dorsal pedis pulse and the posterior tibial pulse, so you want to mark them. And then we're going to take their blood pressure. So we're going to take a systolic blood pressure from each arm, and then we're going to do some math. So we are going to calculate the ankle brachial index by dividing, number one, you have to figure out of the two arms, which is the higher of the systolic pressures. And then we're going to divide it for the systolic pressure from each leg using either the pedal or the post-tibial pulse. So we're taking the blood pressure in the leg using a Doppler. So everybody got that? And then we're going to divide it. So, and I gave you the ranges. A normal ankle brachial index is 0.91 to 0.130. And then anything as it gets lower and lower is saying how advanced the PAD is. So this is a non-invasive way of looking to see, does somebody, number one, have peripheral arterial disease of the lower leg, and how severe is it, by gauging the ankle brachial index. Remember that with somebody with peripheral arterial disease of the legs, you definitely will see a difference in the pulses and in the pressures between the arms and the legs. Some other tests we can do, MRAs, angiograms, I already talked about that. Collaborative risk factors, smoking cessation is going to be, if anybody has PAD, they should quit smoking. Aggressive treatment of hyperlipidemia, so they should be on statins. We're gonna control hypertension and diabetes. We want to maintain blood pressure less than 130 over 85, and for diabetics, we want their A1Cs to be less than 7. They are probably going to be on antiplatelet therapy, so aspirin, of course, could be used, clopidogrel, which is Plavix. If they're in the hospital and they're concerned about the development of emboli with very severe forms, they could be put on heparin when they come into the hospital. There are some drugs that are absolutely prescribed for the intermittent claudication. So probably the number, well, no, you know what, they're kind of equally used. It just really depends on the doctor. So you do want to recognize these names of these drugs for intermittent claudication. Other things that we do for intermittent claudication, we want the people to exercise. So I know that it causes pain, but we want them to continue because exercising improves the chance of collateral circulation development, and it also improves oxygenation to the skeletal muscle. So we want them to walk at least 30 to 40 minutes per day. And they may need to build up to this gradually. So if they're we want them to walk until they get pain, and then they can go ahead and sit down and rest. And the next day, try and walk a little bit more until they build up to this 30 to 40 minutes per day. Nutritionally, we want them to be on a lower cholesterol diet, because remember, we're managing hyperlipidemia aggressively. So we want cholesterol less than 200. We're gonna manage intake of saturated fat. So we're gonna definitely do dietary teaching for them. Some complementary therapy, ginkgo, has been shown to be effective in increasing the ability for walking distance for patients with intermittent claudication. And then our B12, folate, and B6, these help to lower homocysteine levels. Remember, homocysteine also looks at inflammation in the body. So our normal value here should be less than 13. And we are over 13, what it's telling you is that the blood vessels are irritated, and we have an increase usually in LDL levels and an increased risk for blood clotting. So we want to watch those homocysteine levels and get them down. This all just talks about radiological procedures. If they do go to the cath lab, they can open up the arteries in the legs with the balloon angioplasty, just like we do for the heart, and they can stent it as well. Again, every single thing that applies here from the cath lab is gonna apply whether it's the heart or the peripheral vascular that we're doing a procedure on. As far as surgeries go, thromboendarterectomies is most commonly done in the carotid, so as you hear about the carotid endarterectomies. They can also do peripheral arterial bypasses, just like I just talked about the aorta. This is generally the most common surgical approach for anybody that did not qualify or was not able to do the cath lab procedure. Same thing, if it's happening in the bowel, they can do bowel resections if we have mesenteric artery occlusion. So kind of recognize or start to put together some of the common surgeries with what's going on with the arterial vascular system. So this is looking at a endarterectomy where they're opening up the artery and removing the blockage out of the, and it actually, when they pull it out, it looks like a big gob of fat sometimes. Questions on those? Worst case scenario is going to be a acute arterial occlusion, and most of the time this is being caused by a thrombus that is, or embolus that is broken off from a piece of the thrombus. You know that somebody who is having problems from the heart can throw out a lot of clots. So if the clots are being thrown from the heart, of course, we're always watching for a stroke, but if we get past the brain and the clot gets into the aorta, into the descending aorta, well, now they're gonna start to get caught up in the small of the arterial. So they could go to the leg. We can also have non-emboletic sources of arterial occlusion, so that's gonna be things like aneurysms. Thrombi can, again, get stuck anywhere. So the majority of them, if they get past and get into the legs, they're gonna get lodged into lower extremities. specifically popliteal or tibial areas. However, remember that if the clots are coming from the right side of the lung, here's where we're gonna get the pulmonary emboli. So always, always, always be able to recognize the symptoms of emboli based on the location of the body that they're in. With our acute arterial ischemia, what we're gonna see is a sudden interruption of blood supply, so that is going to cause extremity cell death. So no matter where it is, we talked about it in the heart already with an acute occlusion, but if I'm in the leg and I get an acute occlusion, the cells in the leg and the foot only have a limited amount of time before they're going to die in the same manner. So same thing as the embolus from the heart. Manifestations we're looking for are, again, our 6 P's: pain, pallor, pulsiveness, paresthesia. Hypothermia is the inability to regulate a core body temperature, and then paralysis. These are very late signs. So initially, it's that paleness, coldness of the extremity that is telling you without pulses, and usually has pain, that they have an acute arterial ischemic symptoms going on. Without intervention, this is gonna progress to necrosis and get progress to gangrene, and it doesn't take long for it to get there. So this is why when we teach you, check the pulses, and if you don't feel well, go get a Doppler, because it could be a very short period of time, and the person already is having cell death that's gonna require an amputation. At this point, notify the physician, and then we need to keep the extremity as viable as possible during the acute arterial occlusion until they can get there to do something to open up the occlusion. So vital signs, color and temperature of the skin, we're going to monitor the pulses, warm environment, keep them in a dependent position, so they need to remain flat, and the leg should be, or the leg or an arm, in a dependent position. Again, using gravity to get as much blood flow to that area as possible. We don't want to elevate it in this situation. If they start to talk about paralysis or they can't move it, this is a very late sign, and this is saying that the nerves are now dying. So, and now we have not only cell death, we have nerve cell death at this point. Foot drop is going to occur for a patient with any nerve damage, and that is irreversible. So that's gonna cause them problems walking. Paralysis and neuropathy can be permanent even after the revascularization surgery is done. So again, checking pulses regularly, really, really important to the legs. As far as other collaborative care, anticoagulant therapy, they're gonna be started on a heparin drip at that point, which then means they will be followed up with some form of anticoagulant like Coumadin, and that will probably be long term. They'll need a thrombolus embolus removal, whether or not they send them to cath lab or they go to for a thromboendarterectomy or a peripheral arterial bypass. Questions? All right. Now the other two diseases are Berger's disease and Raynaud's phenomenon, and these are the last two that fall into the arterial group. So the biggest thing to remember with Berger's is usually this is young males, they have no arteriosclerosis. This is being caused by smoking. So mainly a long history of tobacco use with no other cardiovascular risk factors. Inflammation is damaging the vessel walls, except for this is so extreme that they end up with multiple amputations.
I don't get 90.
So all of the symptoms we talked about are gonna be there, but what you see is they go gangrene and necrotic very quickly, and they get amputation after amputation.